about 20% of the adverse incidents happened in the ICU. And out of the patients that the incident happened to, there was at least 14 patients with tracheostomy emergencies. So they acknowledged that we need to do more teaching and more management on how to deal with a tracheostomy that gets dislodged or removed in ICU. So we're going to have a quick look at the different types of tracheostomy. So since you've been in ICU, have you seen any tracheostomies being done? And what kind of tracheostomy was it? You're not sure. Did they do it in the unit or did they do it in surgery?
They did it in the unit.
So that's a percutaneous trache. Okay. So that's one that they dilate down and then they put it in the ICU. The other type of trache is surgical tracheostomy, which is done in theatre by the ENT surgeon. Okay. So that has a little bit of a picture of the differences between a surgical tracheostomy and a percutaneous one. Now, it's quite important to know the difference between a surgical and a percutaneous because of how long it takes for a tract to form. Okay, so has anybody got any ideas how long it would take for a formation of a tract?
3 days.
3 days, anything else?
A week maybe.
So for the percutaneous trachees, it can take 7 to 10 days. Surgical trachees can be a wee bit quicker than that. Okay, so that's why it's really important when every patient that has a tracheostomy has an end of bed time that says if it was a surgical or percutaneous type trache, and that's really just to give you the time frame of when that trache went in and is there likely to be a formed tract. So if there is an emergency, you know that trache has been in for 2 days or 3 weeks, and that's quite important because if you've got a trache that's been 3 weeks, you're going to have a nice formed stoma and a nice formed tract. Whereas if you've got a trache that's only been in a couple of days, that's going to close up quite quickly, and it's going to be more difficult to try and manage that. Okay, so Tracy's trache has only been in for a couple of days, so we'll keep that in mind when we go to our emergency management of what we're going to do. One of the other things that happened was the C-pod in 2014, or NCE pod really, in 2014, they looked at on the right track and about trache management, and that every patient, as well as the end of bedside, needed an emergency tracheostomy box. Okay, so if you've seen any of the tracheostomies in ICU, any of the patients, they will all have a box by the bedside. And this is all for the emergency management. So we'll have a quick look at what's in here. We have the algorithm about what to do in emergency. Tracy, you have a look, she's got a size 7 trachea in, okay? So that means in our box we need to have a size 7 trachea and one size smaller. Any ideas why we would need one size smaller?
Okay, so it flows up.
Yeah. So if you have difficulty, if it comes out in an emergency and you can't get the same size in, you've got another option. You can go for a smaller size, and especially if the trache has only been in for a couple of days rather than anything else. Anybody know what these are?
They open around.
Yeah, so tracheidilators. So you can use them in the stoma if you so wish. The other things in the box is you need a stitch cutter, and that's purely for your surgical trachees because they tend to be stitched in either side, and the percutaneous ones don't tend to be as much. And then, very important, head torch. Why do you think we need a head torch?
Because you'll be doing things with your hands.
Yeah. So it gives you freedom, and also you're looking at a tracheostomy tube that is very small, and you're trying to see what's happening. And ICU is not always the best lit area, so sometimes it just gives you that wee bit extra light. We have embryo vessels and non-rebreathe mask. And this is obviously for the patient's face. So this is I can open it for you. This is a pediatric or neonatal mask. ask, what might we use that for in trachea emergencies? What size do you think it would fit over? Where would we address it? Yeah, so that could seal your stoma site if you need it. And the other important things that we've got is suction catheters, really important in all trachea emergencies. And your 10 ml syringe. So what do we think we'd need that for?
Deflating the cuff.
Yeah, for deflating the cuff. So every trachea keeping it in place has got a cuff. And you need to deflate that. The only other things we've got in is some lubrication, and that's if you're needing to reinsert a new trachea. Is everybody happy so far? Yeah? So in NHS Lothian here as well as the trachea box, the head of bedside, we also have a checklist for the patients on the wards that have tracheostomies or laryngectomies in situ. So we'll have a quick look at laryngectomies. Does anybody, or could anybody tell me the difference between a tracheostomy and a laryngectomy? Shall I show you the signs and then you maybe tell me what you think is the difference?
So can you reverse a tracheostomy, but you can't reverse a laryngectomy?
Exactly. So a laryngectomy, they've taken away the larynx and they've separated the airway from the system. Okay? So if you have a laryngectomy patient, they do not have a usable upper airway. Okay? So it's really important if the patient comes in and they've got laryngectomy, they haven't got an upper airway. Why would we do laryngectomies? Do you know? What would be the reason?
They've got a cancer.
So normally it's for malignancy of the larynx. And obviously with your tracheostomy patients, we should still have a patent upper airway most of the time. Why would we, what's the indications for a tracheostomy? Why do we do them?
The patient's having difficulty being weaned off basic ventilation.
So long-term ventilation, yes, we definitely do that because you can use less sedation, you can mobilise the patient easier, and it stops having pressure areas around the mouths. Anything else, any other reasons that you can think of?
There's like obstruction, some obstruction.
So any kind of obstruction of the upper airway, swelling, anaphylaxis, something like that that causes a huge amount of swelling, you can use it. And there's one other, which is probably more long-term patients, so patients with like neuromuscular conditions that need a trachea just to manage their secretions because they're not able to do it themselves. Okay. Right, shall we have a look at Tracy and see if we can save her? Or shall we have a wee think about the red flags first? So, the red flags are kind of put out there as things that would concern you if you were looking after a patient with a tracheostomy. So there's airway red flags, breathing red flags, tracheostomy red flags, and kind of general red flags. So if we start with the airway, what would be red flags or concerning issues with the airway? Just think about what you're trying to do and what you're trying to achieve.
So it's not patent, it's blocked.
But before that, so if you're thinking about when you get to a patient, have they got stridor? Can they speak? Is there bubbling, frothing at their mouth? Because all of those signs show you that maybe this trachea is not doing exactly what it should be doing because they're able to vocalize, which means there's something wrong. Okay? Breathing red flags? What do you think?
Increased respiratory requirements.
Yes, definitely. So increased respiratory, high oxygenation, so hypoxia, apnea, dyspnea, so they're using their accessory muscles, their increased work of breathing. What about the tracheostomy itself? What would the red flags be for that? thinking of? What's the other one that might cause a lot of problems when a trachea's been in for a while? Bleeding. Okay. So quite a few arteries that run close by, and tracheas have eroded into the dominant artery, and when that happens, that's a catastrophe. Okay, so think about those, and then your general red flags are just all the things that you would look at in bed space. So your respirate, your oxygenation, your heart rate, their blood pressure, their GCS, their mental state. Are they more confused? Are they getting agitated? All things to think about in the bed space. Okay, so now that I've got my assistant, we're going to look at what the algorithm tells us to do in an emergency. So, just been called to the bed space.
Okay.
This is Tracy.
Hi, Tracy.
Tracy's had flu, unfortunately, and has been in ITU for quite a while, and has just had her tracheostomy 2 days ago, as you can see on the side. And you've got called to the bed space because she's suddenly desaturated, and when you get there, she's sats are only 82%, and she's got an increased respiratory rate and looks a bit agitated. So what's the first thing that you want to do?
So, having conducted an assessment of Tracy adaptation on that tracheostomy to this job.
Okay. Before we get there, what else would you want in the vicinity or coming close?
So, once I've realised that, I've got additional support.
So,
if I can.
yes. So first thing you want to do is ask for help. You need somebody that can assist you manage an airway and hopefully do advanced airway skills. So first thing you do, take your time, you call for help, okay? Then what you're going to do?
I've got a follow the
So the algorithm says next thing we do is we look, listen and feel. So where are you going to look, listen and feel?
So I'm looking at Tracy as a whole, so I'm looking obviously at her upper chest. I'm good to see if there's any chest discussion at all, right, all around chest. I'm going to have a listen.
And you want to listen at the mouth and at the tracheostomy site, because you're not sure where everything is at the moment. The other thing that came out of the NAT4 trial was that capnography should be on every patient that has a tracheostomy. So every patient should have an end-tidal CO2 at their bed space. So that is your biggest indication whether the tracheostomy is in the right place. Okay? If you have a CO2 trace with every breath, you know it's in the right place. The algorithm also suggests that you use a Mapleson C circuit, which I'm always slightly dubious about. I think if you want to attach it, all you can do is see if the bag is moving. Because if I was to give Tracy a big blast of air and the trachea is not in the right place, what's likely to happen? So if that's in the subcutaneous tissue, and I give her a massive big breath, trauma, you're going to end up with huge surgical emphysema in the neck, because you've just given them a huge bag down to a trachea that you don't know is in the right place. So I'd be very careful with the C circuit, and you can use it if you've not got capnography just to purely see if the bag's moving, but be very, very cautious about bagging a tracheostomy that you don't know is in the right place. So on the algorithm, so we've looked, listened and feel. The next thing we do is the patient breathing, and she is breathing, and we want to apply oxygen. Where are we going to apply the oxygen? Anybody have any ideas? Now it's a tracheostomy patient, which means she also has a patent upper airway. So where are we going to put the oxygen? So both, yes. So we want to put some high flow. You want to do that? And she's already got a lovely TB, so we'll put 100% oxygen through that as well. Okay, so she's got oxygen applied to the stoma, and we're going to apply high flow oxygen to her face as well. Okay. So we know she's still breathing, she's got high flow oxygen on both sources. And then we want to assess the patency of the trachea. How are we going to do that? What's the best way to assess if it's patent? Okay, you want to suction. Okay, so at this point we're going to remove the oxygen. We're going to remove any caps or speaking valves or anything, and then we are going to remove the inner tube out of it. Why do you think I want to remove the inner tube?
Should make it obstructed.
Yeah, very much so. So this could be locked, and that might be enough to give her some air in there. So we've taken out the inner tube, and then you want to suction. So the next question on the algorithm is, can you pass a suction catheter? And no, you can't pass a suction catheter. So what do we need to do now? So we cannot pass the suction catheter. We don't have capnography. Where do we think the tube is? Is it in the airway? No, probably not. So the next thing we want to do is deflate the cuff of the trachea. Very good. And that way, so when you've got your cuff up, you're creating basically a area that you can't get any air through. So when you take the cuff down, the tube is much smaller in the trachea, and you can get air around the tube. And then we want to reassess our patient. Has that made her feel any better? And because we know we can't get a suction catheter down, she's still deteriorating, and we've now deflated the cuff, but she's still getting worse. What do you think we need to do now? And this is the bit everybody finds very difficult. So we have a tracheostomy tube that we can't guarantee is in the airway. So it could be blocked, or it could be in a false passage, okay? So is it doing any good? No. So what do we want to do? Take it out. Very good. And this is always what people struggle with, because everybody's like, oh, there's a trachea, you've got to leave it. But if you cannot guarantee it's in the right place, then you take that trachea out. And then what you want to do is seal over the stoma and go to the top end again. And then you do standard manoeuvres to manage her airway until you have help, okay? And then you could use, so your bag valve mask, you could go back with an ET tube or use an LMA until you've got more help, depending on the skill set up there. If that's still becoming a problem and you feel like you've got a stoma that actually works, you could use LMA over your stoma, or your, somebody passed me a pediatric face mask. You could use your pediatric face mask, okay? But that's very much second line, and you would go top end to start again. Any questions? How would you feel about doing that?
Confident.
That's what I like to hear. I suppose what you've got to remember is that you will have help coming, okay? And as long as you've done that, the first thing on your algorithm, that you have called for help, you've got somebody coming to assist you with this airway. You are never going to get into trouble or have a problem because you've taken the trachea out. If it's not in the right place and you haven't got capnography and you can't suction down it, it's not doing any good. And the other thing to be aware is when you have, if it is moved into a false track, sometimes that can press on the airway even more. And the other thing that can happen is once a false track is made, it's really easy for things to go back into that false track. So going for your standard upper airway manoeuvres is your safest way. I've had quite a few trachea emergencies in my time, And I think out of all the emergencies I've been to, we've only ever once managed to put a tracheostomy back into the stoma. So just keep that in the back of your head, as long as you can manage your airway. Now, just to finish off with laryngectomy patients, obviously they don't have an upper airway. However, if you're not sure if it's a laryngectomy or a trache, you can put oxygen on both points. But if you know it's a laryngectomy patient, you have to try and use the stoma non-blockade. And you want to do the same, so you ask for help, you look, listen and feel, you assess, you can use your end-tidal CO2, your capnography, or your bag to see if there's any air movement. You remove any caps, anything that's in it. Quite often they have speaking valves and things in their stomas. You want to remove all of that. And laryngectomy patients don't always have tubes because they're long-term. So there might not be an inner tube to remove or any tube to remove, but you still need to check the patency of that airway. You have to suction. Okay? And then you go through, and that's when your little pediatric face mask comes in handy, that you can seal that. And if you don't have this, then you can use an LMA, because that will give you a nice seal over it as well, just holding it. We've only got really two types of trachees. We have the Portex ones, and we have adjustable phalanges. The adjustable phalange is longer. What do you think we might use that for? What is the epidemic going to be in the next 30 years? Obesity, yeah. So moving forward, we're going to have a lot more patients with larger necks and shorter necks, just because of weight distribution. And sometimes you use an adjustable flange. And adjustable flanges have an inner tube the same. They're just longer, and you can clamp it where you need it. And this is the Portex trachea. And they come with an inner tube and a spare inner tube. And you have a cuff that holds it in place and seals your trachea. Okay? And when trachees are put in, it should be taken into account the size of the patient and how big they are. So obviously, Tracy's very small, so she's got a size 7, which is quite small. And if you've got a larger male, you might want an 8 or a 9. And obviously, your obese patients, we would probably go for an adjustable flange rather than this. You can have a wee shot. Now, does anybody want a shot? We can go through the algorithm again, and somebody else can have a shot. Don't all jump at once. Right, when I get the trachea back.
Read out the algorithm whilst everyone does it.
Yeah? One of you want to have a look at the algorithm?
Tell me you play that card.
And because it's clinical, we should need lots of those.
He is encouraging us.
Okay, so this is day 1 in MEU. You're it. You're the FY1 on. No, it's fine. So, don't be stressed. Just think about it, and we'll work through it. And Oliver's going to call out what you need to do next. Okay.
A few times on help.
See, God listening.
Say when.
No, you can't get his blood flow. Okay, so I can be the nurse at Bisbee. So Oliver's over there. I've got a problem with my patient. She's suddenly desaturated, and now she's getting really agitated, and she's moving all around the bed. I don't know what's wrong with her.
Okay, that's fine. Just looking at her just now, has she been making any breathing sounds or anything?
Oh, she is actually. Yeah, I think you're right. eyes. She was trying to talk to me earlier.
Okay, and what did that sound like? Did it sound...
Well, she just sounded like she had a voice.
Okay, that's fine. So hopefully that's...
So, what's the first thing you want to do in your algorithm?
Call for airway expert help.
Okay, so first we should call for someone more senior.
Should I go and do that?
Yeah.
Lovely.
Thank you.
And if you could look, listen, and feel at the mouth and tracheostomy.
Okay, so... Okay, should I take this off?
Yeah.
Just have my tracheostomy. And this is... Whoa.
No, she is speaking, yeah.
She's speaking. Oh, okay.
But she's got a respiratory rate of about 40 now, and her sats are 76.
Okay.
What should we do now?
Yeah, so I think we should, it'd be good to have some oxygen.
Okay, where would you like that oxygen?
Have some oxygen on her, over her mouth, as well as over the tracheostomy. So I'm just going to put an oxygen mask on your face there, and
Put some high flow in this.
I'll put some. Okay.
Good. Assess the tracheostomy patency.
Okay, so what do you need to do next?
Now, we need to suction.
So before you do that, you will suction, but you need to take off any caps, inner tubes, anything that's on top, like a passing valve, a speaking valve. So you don't want to take your cuff down just yet. So what we'll do is just take out her inner tube. So just pull. Okay.
That's
So that's the
remove
inner tube.
speaking valve or cap and remove inner tube.
Lovely. So you've removed the inner tube. Oh, it looks okay. Not too much of a problem. But she's not getting any better. So keep the oxygen on.
Can you pass a suction cap?
So can you pass the suction cap?
Yeah, let's find out. This. Okay.
She's... Oh no, that suction cap is not going anywhere. Oh, and it looks like it's got a big glob.
What colour is it?
It's kind of creamy colour.
So
So you can't pass the suction catheter.
I think it might be time to take out the tractor.
Do you think? What are you going to do before you take it out? What you wanted to do earlier.
It's like the car.
So we've deflated the cup, and then we're going to go back and assess.
Okay.
So look, listen, and feel at the mouth and tracheostomy.
Okay.
She's still quite agitated, and she's all over the place. And our sats are only 70 now.
So maybe basically still dropping. Okay.
And your help's coming, but it's not here yet. So what we're going to do?
Remove the tracheostomy tube.
Okay. I'm just going to remove the
So it's
tube.
you need to take
Okay.
the tapes off.
Sorry, but
And that is very much real life. Is sometimes they can be really sticky and they can be really caught. So we want to, you get a friend to cover, and then what will we do now? We can do, or we can try. What would we do? Possibly before we do a trick face mask. What's our first manoeuvres?
head to chin.
Yeah, so you can back off mask, LMEs. Do that first before we
Okay.
get to